Hello, I'm Dr. Jimmy Douglas, and today we are going into details of PCOD or PCOS, polycystic ovarian disease or a polycystic ovarian syndrome. It is called syndrome because it has a group of symptoms. PCOD or PCOS, both the terms are used to describe it. Watch the video till the end to understand it thoroughly. What is PCOD? It is a hormonal disorder in women of reproductive age affecting 5 to 10% of women worldwide, which presents itself as irregular periods or no periods, abnormal lipid profile, there is weight gain, and there is increased risk of diabetes and hypertension. While the exact cause is not known, the probable causes, apart from being hereditary, it is associated with increased insulin and increased androgen levels. By androgens, I mean testosterone. I've tried to simplify this topic for you to understand. Let's see how a case of PCOD presents itself to doctors. While an 18-year-old female may consult me for weight loss, while a 25-year-old female may visit a dermatologist for acne or hair fall, while for a gynecologist, the presenting complaints by a 30-year-old woman may be irregular periods or not able to conceive. So we have to investigate to rule out other conditions which mimic or resemble PCOD and then come to a diagnosis, which essentially is a diagnosis of exclusion. Diagnosis of exclusion is we are excluding all other diseases which might resemble PCOD, and then we are coming to a diagnosis. We have to check if it's just obesity which is causing all the problems, or whether it is due to hypothyroidism or hyperprolactinemia, or whether it is due to non-classical congenital adrenal hyperplasia. So, detailed medical and family history of PCOD, diabetes, hypertension, obesity are taken along with the following investigations to rule out other conditions and then come to a diagnosis. Lipid profile and blood sugar testing is done because PCOD patients are more likely to have metabolic syndrome, and it is also known to be associated with sleep apnea and depression. In differentiating obesity and PCOD, the circulating androgen levels in the blood of obese patients are not increased. Even though the production of androgens is increased in obesity, the clearance rates is also increased. So we don't find increased androgen levels in the blood. Now looking at the Rotterdam criteria, number 1, menstrual irregularities. 2, clinical or biochemical evidence of increased androgens. 3, ultrasound appearance of polycystic ovaries. The presence of 2 out of 3 are required for the diagnosis of PCOD. Menstrual irregularities could be absence of menses, irregular periods, or heavy bleeding. Here, clinical evidence is by presence of hirsutism, where there is excessive abnormal growth of hair on the face and body, and patients are worried about the presence of acne and darkening of the skin at the back of the neck and under the arms. And biochemical evidence is by raised serum testosterone. After excluding conditions which cause raised serum testosterone like androgen producing tumor and Cushing's disease. In ultrasound, the presence of at least 12 or more follicles measuring 2 to 9 mm in size and at least one ovary having an ovarian volume of greater than 10 ml. Here you can see a lot of small follicles which are of the same size and not growing. Women diagnosed with PCOD might be lean and might be having normal menstrual cycles. Since there are different observable traits and presenting complaints, women with PCOD have been diagnosed into different types like type A, B, C and D. Why all this is happening? Why there are no menses? Why there are irregular periods? Why there is increased androgens? Why the ultrasound is showing polycystic ovaries? To understand all this, we have to understand the hormones involved in PCOD. Before that, we'll see the hormones involved in the menstrual cycle. GnRH is gonadotropin releasing hormone from the brain. FSH is follicle stimulating hormone, and LH is luteinizing hormone from the anterior pituitary. Estrogen and progesterone are ovarian hormones. Here you can see the inner lining of the uterus is endometrium. Menstruation or menses is shedding of this thickened endometrium from the uterus through the vagina. Menstrual fluid contains blood, cells from the lining of the uterus and mucus. Now listen carefully to understand this. GnRH in the brain stimulates the pituitary to secrete FSH follicle stimulating hormone, which helps in the growth of immature ovarian follicles. Growing ovarian follicles secrete estrogen, and this estrogen acts on the uterus to cause proliferation of the endometrium. Increased estrogen sends signals to the brain for LH surge, for the release of the egg from the mature follicle. After LH surge, the follicle is ruptured and the egg is released and into the fallopian tube. It has 24 hours to get fertilized with sperm. The ruptured follicle stays in the ovary and it's called corpus luteum. It starts secreting progesterone, and this progesterone makes the endometrium secretory, preparing for the developing embryo to come and get implanted. Progesterone gives feedback to suppress LH. If fertilization doesn't happen, then corpus luteum degenerates and progesterone stops. And due to progesterone withdrawal, endometrium starts to shed off and menses happen. And this cycle is repeated every month. If fertilization happens, then where does it happen? It happens when sperm meets the egg in the fallopian tube. You can see the sperms are moving towards the egg from the vagina into the uterus to the fallopian tube. It only takes a few minutes for the sperm to reach the fallopian tube, and if fertilized, they come to the uterus and get implanted in the endometrium, which is in the secretory phase. What happens in PCOD is there are multiple immature small ovarian follicles which are 2 to 6 mm in size, called antral or pre-antral follicles, which are not increasing in size. These go on making estrogen, and estrogen causes proliferation of the endometrium. When there is enough estrogen, it sends a signal to the brain for LH surge, and when there is LH surge, the egg has to be released. Now, the criteria for the egg to be released is the follicle has to be mature, around 20 mm in size. But here we can see the follicles only 2 to 6 mm in size, so it is not released, and this causes anovulation, that is absence of ovulation, and the patient complains of no periods or infertility. In normal cycle, we have seen that after the egg is released, corpus luteum is formed and corpus luteum secretes progesterone. Progesterone causes the endometrium to become secretory. Here in PCOD, no egg is released. There is low progesterone because there is no corpus luteum, and because of low progesterone, there is no secretory phase in the uterus, and there is no feedback to the brain to stop LH. LH keeps on rising, and this persistent high LH acts on the stroma of the ovary to produce androgens. High LH causes high androgens, and clinically we see hirsutism. There is excessive abnormal growth of hair on the face and the body, and the presence of acne. Normally we saw that menses happen due to progesterone withdrawal. Here in PCOD, there is no progesterone. Estrogen is high, and this causes constant proliferation of the endometrium. And this constant proliferation of the endometrium can't go on endlessly in a closed uterine space, which causes excessive endometrial overgrowth, which leads to unpredictable bleeding patterns. And the patient may complain of irregular bleeding or bleeding every alternate week, or there could be heavy bleeding. Whenever the patient has irregular bleeding, generally the patient is not ovulating. By this time, you might be wondering why the follicle is not increasing in size. This happens because of insulin resistance. That is, the body is not able to utilize insulin, and the function of insulin is to promote glucose uptake, and there is low glucose in the follicle, and the follicle is not able to grow. When the body is not able to utilize insulin, then the insulin level rises. So we see there is high insulin, and these are the lab values which we see in a PCOD patient. Treatment of PCOS. PCOS was first described by Steen and Leventhal in 1935. So this is not new, but the incidence is increasing because of the changes in the lifestyle. Weight reduction is the first line of treatment, and just 5% in weight reduction will help you get the periods normal and increase the pregnancy rates. Women who are overweight should try and get it down by exercising regularly. You could follow a calorie restricted diet of 500 kilocalories less than your daily calorie requirement. Stop smoking, as that would aggravate the condition. I know it's easier said than done, but it's important for you to prepare your mind to start exercising and to to change your lifestyle. And also, it is important for you to seek help if there are any issues troubling you. Talk to a counselor or your friends or your family members, but most importantly, start exercising and take the first step. Keep walking and exercising. Also, you can check our videos on weight loss. Women who don't want to conceive in their present situation are given oral contraceptive pills. The pills are given for 21 days and stopped for 7 days when bleeding happens. And it also helps in reducing hair growth in 2/3 of patients with hirsutism. There are drugs which help in inducing ovulation, and sometimes injections are also given. And then there are also drugs for excessive hair growth on the body, acne, and for high blood glucose. If the patients are found to be resistant to drugs, then laparoscopic ovarian drilling is done. Here, around 6 holes are drilled in the stroma of the ovary to decrease androgen producing tissue and to promote ovulation. Thank you for watching. Click on the subscribe button and turn on the notifications. See you in the next video. Bye-bye.